Acute coronary syndrome, Part 4. Number 3, anti-anginal therapy. Sublingual glyceryl trinitrate in a dose of 300 to 500 micrograms is a valuable first aid measure in unstable angina or threatened infarction. And intravenous nitrates, glyceryl trinitrate in a dose of 0.6 to 1.2 milligrams per hour, or isosorbide dinitrate in a dose of 1 to 2 milligrams per hour, are useful for the treatment of left ventricular failure and the relief of recurrent or persistent ischemic pain. Anti-anginal therapy. Intravenous beta blockers, for example, atenolol in a dose of 5 to 10 milligrams or metoprolol in a dose of 5 to 15 milligrams given over 5 minutes, relieve pain, reduce arrhythmias, improve short-term mortality in patients who present within 12 hours of the onset of symptoms. However, they should be avoided if there is heart failure or pulmonary edema, hypotension with a systolic blood pressure less than 105 millimeters of mercury, or bradycardia with a heart rate less than 65 beats per minute. Reperfusion therapy. In non-ST elevation acute coronary syndromes or non-ST elevation myocardial infarction, immediate reperfusion therapy has no demonstrable benefit in patients, and thrombolytic therapy might be harmful. Selected medium to high risk patients do benefit from in-hospital coronary angiography and coronary revascularization, but this does not need to take place in the first 12 hours. Early invasive strategy within the first 48 hours in selected medium to high risk patients as identified by the GRACE score. Again, the GRACE score is the Global Registry of Acute Coronary Events score. It identifies patients who are at intermediate or high risk, and those patients benefit from an early invasive strategy in patients with non-ST elevation myocardial infarction, and an early invasive strategy is within the first 48 hours. STEMI, or ST elevation myocardial infarction. Immediate reperfusion therapy restores coronary artery patency, preserves left ventricular function, and improves survival. Successful therapy is associated with pain relief, resolution of acute ST elevation of more than 50%, and sometimes transient arrhythmias like the idioventricular rhythm. Reperfusion therapy in STEMI. The other option is primary percutaneous coronary intervention. This is the treatment of choice for ST elevation myocardial infarction. Outcomes are best when it is used in combination with glycoprotein 2B3A receptor antagonists and intracoronary stent implantation. In comparison to thrombolytic therapy, it is associated with a greater reduction in the risk of death, recurrent myocardial infarction, or stroke. The universal use of primary PCI has been limited by availability of the necessary resources to provide the highly specialized emergency service in all locations. Thus, intravenous thrombolytic therapy remains the first-line reperfusion treatment in many hospitals, especially those in rural or remote areas. When primary PCI cannot be achieved within 2 hours of diagnosis, thrombolytic therapy should be administered, and this was seen in the management algorithm that we pointed to in Part 3 of this lecture. Thrombolysis. The appropriate use of thrombolytic therapy can reduce hospital mortality by 25 to 50%, and this survival advantage is maintained for at least 10 years. The benefit is greatest in those patients who receive treatment within the first few hours. And the famous saying is, time equals myocardium or minutes mean muscle. Reperfusion therapy thrombolysis. Alteplase or human tissue plasminogen activator or TPA is a genetically engineered drug that is given over 90 minutes. As such, a bolus dose of 15 milligrams followed by 0.75 milligrams per kilogram body weight not exceeding 50 milligrams over 30 minutes, followed by 0.5 milligrams per kilogram body weight but not exceeding 35 milligrams over 60 minutes. Its use is associated with better survival rates than other thrombolytic agents such as streptokinase, but carries a slightly higher risk of intracerebral bleeding. An overview of all large randomized trials confirms that thrombolytic therapy reduces short-term mortality in patients with myocardial infarction if given within 12 hours of the onset of symptoms and if the ECG shows bundle branch block or characteristic ST segment elevation of more than 1 millimeter in the limb leads or 2 millimeter in the chest leads. Thrombolysis appears to be of little net benefit and might be harmful in those who present more than 12 hours after the onset of symptoms and in those with a normal ECG or in those with ST segment depression. In patients with ST segment elevation or bundle branch block, the absolute benefit of thrombolysis plus aspirin is approximately 50 lives saved per 1,000 patients treated within 6 hours and 40 lives saved per 1,000 patients treated between 7 and 12 hours after the onset of symptoms. The benefit is greatest for patients treated within the first 2 hours. Intracerebral or intracranial hemorrhage is more common in people given thrombolysis, with 1 additional stroke for every 250 people treated. For some patients, thrombolytic therapy is contraindicated, and this will be listed in the next slide. Thrombolytic therapy is contraindicated or fails to achieve coronary arterial reperfusion, meaning that the patient is given the thrombolytic therapy and the favorable desired effect of thrombolytic therapy is not observed. No ST segment resolution, chest pain still persists. In such cases, early emergency PCI may then be considered, particularly when there is evidence of cardiogenic shock. What are the contraindications to thrombolytic therapy? Number 1, active internal bleeding. Number 2, previous subarachnoid or intracerebral hemorrhage. Number 3, uncontrolled hypertension. Number 4, recent surgery within 1 month. Number 5, recent trauma, including traumatic resuscitation. Number 6, high probability of active peptic ulcer. Number 7, pregnancy. Part 4, acute coronary syndrome. Thank you for listening.